Hi, my name is John Mellinger. I want to thank Dr. Lack and Dr. Hussein for the privilege of being part of this panel, and also thank the program committee for this opportunity to be part of the excitement of this virtual SAGES meeting. We'd all rather be together, but we appreciate the chance to be together this way. I'm going to give the opening talk here on this wonderful panel looking at surgery in the Millennial Era, and I'm going to talk about fellowship training in 2020 to help set the stage for some of the rest of the panel discussion. I have nothing to disclose. I'm going to cover these topics briefly in the course of our talk, why fellowships are pursued in this era, what fellowships are currently available, where do fellowships fit into the whole spectrum of advanced surgical training, promises and pitfalls of fellowships we'll dwell on briefly, and then talk a little bit about important future considerations. Obviously, one of the main reasons for pursuit of fellowship is the growth of medical knowledge. It's estimated to be doubling about every 18 months now. We all know that the quest for mastery is an important part of human motivation in tasks that involve significant cognitive effort. I love a quote from Harvey Cushing on this theme, who said that one of the most fulfilling things he had experienced in medicine was to find an area of practice that he could feel he had truly mastered, which obviously for him was neurosurgery in its nascent form. So growth of knowledge certainly propels people to seek areas where they can feel they have a better chance of achieving mastery and focused knowledge and skill. Many of our residency graduates struggle in this era, as in all honesty, I think most of us did in some sense, regarding confidence in their skills and the spectrum of skills they need. This depends obviously on the experience they gain in their original surgery residency. But given the complexity of the training environment in the present day, both with reference to knowledge, technology, and other pressures, this is definitely something our residency graduates struggle with. Duty hours have had something to do with that. There is an estimated 20% decrease in total time spent in the clinical setting since the duty hour regulations came to be, and an estimated 50% decrease in night and weekend duty time related to night float and other models, which is obviously a time frame in which many develop autonomous function experience. And so this has certainly put added pressure on the training setting. I'm not saying that to critique the duty hours. Having trained before them, I can tell you that much of what I experienced and my colleagues was not of educational value and created many other pressures and unhealthy influences in our lives. But it's definitely a pressure our residents feel. There are potential quality of life, depending on the specialty chosen, and financial implications of fellowships, and this affects our learners in their decisions. And obviously those with academic career interests sometimes go into fellowships because it helps equip them either academically and research-wise, or in terms of specialty focus for a more tertiary or quaternary environment in which they hope to function. With reference to the issue of resident confidence, this is a study we were privileged to be part of that Mark Friedel was the primary author for, published in JACS in 2014, that surveyed, it was almost 300 chief residents regarding their comfort level with common procedures. You can see from the graph that as the complexity of the case went up and as the volume of experience went down, the level of confidence predictably decreased. And so there were procedures that most graduating chief residents felt very comfortable performing in practice, but others less so, such as major hepatic resection or esophagectomy. So depending on the practice niche, the level of confidence the resident has in the training they've received in a typical general surgery program will indeed be variable. This is a depiction of some of the fellowships that one can pursue from a general surgery background. I often say to my own residents, you've chosen to be a stem cell a little longer by not choosing an early specialization pathway or a subspecialty residency immediately after med school. These options are very different with regard to how they are regulated. Some lead to board certificates. Some are able to be pursued through specialty society pathways. Some one can gain entry to from several different residency backgrounds. And some differentiate further into further subspecialties. So a very variable environment, many options available in the current setting, probably more than 25 different pathways a resident could pursue in this era and increasing. I think it's important to highlight that fellowship is one option within a number of advanced surgical training and specialization pathways. I've listed those here. I will not go into each of them, but one can do various, either directly go into another specialty such as neurosurgery, orthopedics, urology, ENT, straight out of med school. One can go into integrated programs such as exist in plastics, vascular surgery, cardiothoracic surgery now. One can do combined programs that involve longer periods but not complete periods of training in a general surgery structure and then specialization. One can do a lot within the structure of a general surgery residency. I would reference an article there. I've given you the reference for published in the American College of Surgeons Resources and Surgical Education series. Kyla Terhune was the first author, who's a wonderful young surgical educator and is now the DIO at Vanderbilt, that outlines how much can be done within a standard 5-year structure to develop specialized skill sets in fashions approved by both the ABS and the ACGME. There are also programs usually that have very strong clinical programs of a varied nature that allow a cohort of residents to each choose ways to spend up to 12 of their final 24 months with a specific focus, flexibility, and surgical training, so-called pathways. And even post-training, there is now the ABMS-approved focus practice designation strategy to designate people with specialized skill sets whose practices have evolved in such a direction. So many pathways, of which fellowship training is indeed one. We don't have time to go through everything on this slide, but I would just highlight that there are promises and pitfalls of the fellowship training paradigm. And as a person who has spent a number of his years as a general surgery residency program director, I can tell you that while most of my residents who have gone on to fellowship training have had great experiences that achieved many of the things highlighted on the left side of the slide, a not insignificant minority have encountered the things on the right side where they were used for service rather than made a focus of specialized educational emphasis, where institutional agendas turned out to be the reason they were there rather than educational agendas, where their presence competed rather than complemented with resident experience at the institution, and where there were priorities that really weren't conducive to what our societal needs are, or even settings where international fellows were really utilized for inexpensive service rather than to help their native countries or themselves. So it's a mixed bag. It's improving. SAGES and the Fellowship Council have done a lot in this space, but I think it's important that people consider the individual fellowship and the individual learner and not view this as a one solution fits all needs or one institution achieves all desired outcomes as one considers where fellowships fit. This is one example of the mixed influence fellowships can have. Financial impact is obviously not the most important thing, hopefully to any of us, and hopefully not to most of our learners, but it's quite variable, at least through this formula that was used to analyze it in 2014 in an American Surgeon article. You can see that some disciplines ended up being conducive to financial gain for the trainee, and some actually had a negative impact compared to general surgery. So what would this lead us to say if we were considering the future? I think it's important to realize that advanced surgical training and fellowships as part of that spectrum exist at a busy intersection and a bit of a moving target with regard to societal needs around specialized care, around the growth of medical knowledge, around an increasing emphasis on patient outcomes, and a fiscal environment that frankly is changing with regard to how graduate education is financed. I think it's important to consider all the options I listed on an earlier slide with regard to educational outcomes, that fellowship doesn't have to be the only solution. And I think residency program directors and fellowship program directors should be creative in considering what the best options are for a given learner. I think it's very important as we think about what the future of fellowship training should look like to keep a focus on education and not using fellowships as agenda strategies for achieving other things that are not focused primarily on developing an excellent practitioner. And this gets into Simon Sinek's famous question of what's your why? It has a lot to do with the outcome. And finally, I think that we need to recognize that fellowships don't exist independent of the rest of the medical education paradigm, and that competency-based education with learner and teacher accountability and habits of assessment and improvement need to be built into the fellowship paradigm as much as any other. If it's the terminal training paradigm we use for many of our trainees in this era, I think, again, SAGES and the Fellowship Council are doing some great work in this space. Just some points for reflection as I conclude. I think, as many of you know, there are now studies done such as that Rachel Kells and her colleagues at Penn have done that show that the impact of the training environment can be traced into patient outcomes, including mortality, complications, length of stay, and failure to rescue for long after we do our training. And this imprint is a critical thing to think about if fellowships are going to be the terminal phase of surgical training for many of our learners. I also think, particularly as surgeons, we need to recognize in the context of the pandemic that our generally fiscally and technologically heavy patient care model has not resulted in a nimble and public health accountable system in a setting where it was desperately needed. It's proved to be expensive. It's proved to be hard to sustain. It has proved to have done a very poor job of delivering care for the most vulnerable. And as a profession and as surgeons, we are accountable for that and should think about what we're training people for if we move people away from broad general surgical skills and the public health needs of our society in increasingly technologically driven directions. I recognize these are complex topics, but we shouldn't leave them off the table as we consider what fellowship should or shouldn't be. And finally, I think as we think about those things, we should remember that our learners are watching what we do and not just what we say. What are we modeling in the fellowship training model for the future providers of surgery to our population? I will stop there. I thank you very much for the privilege of being part of this panel and look forward to the rest of the panelists.